everyone, my name is Kimberly Loke, and with me is my colleague Kylie Melville. Today we'll be presenting on our paper titled Reflections, Resilience and Recovery, a qualitative study of COVID-19's impact on an international general population's mental health and priorities for support. As in the title, the paper examines the impact of COVID-19 as a stressor that has resulted in changes in people's living environment, mental health, and relationships. Seeing that there is a gap in literature for qualitative studies to identify why some mental health symptoms are stable and why others change, we hope that our data would be able to identify what support would be needed to alleviate the impact of COVID-19 for different groups of participants. The 4 research questions we had were: how did COVID-19 impact people's mental and physical health? How did the impact differ by country, gender, age, and SES? What support do people need? And what are the differences in experiences and desired solutions? If you're wondering how we managed to garner enough data across countries, our qualitative study is based on 5 open-ended questions embedded in a larger battery of questionnaires administered as part of the UCL-Penn global COVID study. Specifically, we thematically analyzed 925 qualitative responses on the impact of COVID-19 on health and the types of support needed. We developed 13 codes across 3 consensus meetings, which was until we achieved an inter-rater reliability of more than 80%. The 3 biggest themes we found were related to participants' outlook on life or self-improvement in terms of increases in behavior, and loved ones relating to family and friends. 82.7% reported COVID-19 restrictions negatively impacting their livelihoods. And while some participants reported feeling more resilient and successfully implemented coping strategies, others suffered from worsened mental and physical health. In terms of support, while 2.91% did not require additional support, 91% requested for support beyond that of financial. We also discovered certain demographics who struggled disproportionately, including those of single parents and individuals living alone.
One of the questions we sought to answer was whether there were any group differences in experiences and kinds of support for post-pandemic recovery. We found small but significant group differences between participants from the UK and the US and Italy, and the UK and Greece. However, we must note that over half of our participants were from the UK. We also found a significant difference between male and female participants, noting again most of our sample was female. Interestingly, we did not find any differences between participants aged above or below 38 or participants who earned more or less than $50,000 per year. Future research could examine in more depth reasons as to why age and income were not significant differentials. However, we must acknowledge that our study is not without limitations. Firstly, for lacking pre-pandemic data on participants' situation and health. Self-report data can be misconstrued by researcher bias, no matter how diminished. Future studies could triangulate participant data across official clinical health databases along with their self-report data. Secondly, our survey was distributed to a global convenient sample, thus not allowing for follow-up elaborations and translated responses from non-English speakers. Although great care was taken to translate such responses, they may not capture the unique nuances these participants may have intended. Thirdly, the countries we collected responses from differed greatly in terms of COVID-19 restrictions. For example, mandates for face coverings depended on individual state and county legislation in the US, European nations were the first to use vaccine passports, and the UK experienced multiple national lockdowns. Future qualitative studies from specific countries can address this limitation. Despite these limitations, this study has several noteworthy strengths. At the time of data collection, this was the first study to examine the pandemic's impact on a range of socioeconomic, behavioral, and mental health factors in a large cross-cultural sample. Thematic analysis was conducted blind to participants' demographic data to minimize researcher bias and increase validity of our interpretations. Most importantly, the participants were highly motivated and gave detailed responses, reflecting a strong willingness to share their insights with the study team. It is clear that COVID-19 and the accompanying restrictions have negatively impacted livelihoods. However, one powerful silver lining was that it gave participants an opportunity to reflect on their lives and how to make positive changes for the future. Many participants want more than just financial support, emphasizing the necessity from governments to support and carry out holistic recovery policies and initiatives. Local communities and authorities can help bridge citizens' growing dissatisfaction towards their leaders and repair these relationships so that we are all prepared for any future pandemics that may arise. On behalf of the UCL-Penn Global COVID Study Team, Thank you for listening to our presentation, and we hope you enjoy the rest of the conference.